American College of Clinical Pharmacy and participant in the Patient-Centered Primary Care Collaborative. We're happy you joined us today for a webinar on principles and values of team-based care. I was fortunate enough to be part of the author team of folks who put together this paper in the last few months around principles of team-based care, and we were invited by PCPCC to deliver this webinar and cover some of this material. And hopefully pique your interest in pursuing going to either the PCPCC website or the IOM website to actually obtain the paper and learn more about it and share it with colleagues and discuss it in your practice settings. We are excited to have been able to do this work. We know, as you see in the second slide, Dr. Carol Aschenbrenner with AAMC, who has been an active part of the IOM collaborative that has helped and supported the assembly of this paper, has made the point, as have many others, that that the kind of healthcare we want to deliver, that is high quality, accessible, person-centered, has to be a team effort. We just can't do this singly as individual health professionals anymore. It's too complex, it's too challenging, and to get this accomplished, we really are going to have to do this in teams. Dr. Aschenbrenner has actually been an active part of the enterprise that helped generate this discussion paper in the first place. On the webinar today, on the webinar today, we have 4 of us who were involved in the preparation of this paper. Myself, Pam Mitchell from the University of Washington, a nurse educator dean, Matt Winia with the American Medical Association, physician interested in working on the issue of patient engagement, among many other things at AMA, and Robin Golden with Rush University Medical Center, and we will each be presenting little bits and pieces of this paper. Sally O'Kuhn was scheduled to join us, but at the last minute was unable to do because of a issue of vertigo. I accused her of having contracted Potomac fever because she's been in Washington for the last 3 or 4 days, and she obviously didn't get immunized against Potomac fever. So we send her our best, and we're sorry that she can't be with us. The other participants in the development of the paper are listed there on that slide. Just a brief word about the Best Practices Innovation Collaborative, which is part of the work of the IOM's Roundtable on Value and Science-Driven Healthcare. We've been working, all of us who've been involved with this paper have been working within that group for the last 2 or 3 years around the issue of advancing a more value-driven and value-based and science-driven healthcare delivery enterprise, and one that also supports a learning healthcare system. This discussion paper, the second of 2 that have been developed as a result of the work of the collaborative, follows an initial one around issues of effective patient-clinician communication, and in fact a third paper now is just being ready to be developed around the issue of patient engagement, and I suspect Dr. Winia will have some other things to say about that whole issue as we get further along in the webinar. There's a lot of common ground between what we've been trying to do with the Best Practices Innovation Collaborative around team-based and patient-centered care and what PCPCC is all about as well. And that really has been at the heart of the reason why we've kind of gone back and forth between the organizations to try to assemble this effort. But there's an awful lot of common ground here, and I think that's obvious to the folks who would have tapped into this webinar because of your commitment to the work of PCPCC and advancing patient-centered and team-based care. Patient-centered is a focus in both efforts, I think. We're talking about comprehensive and truly coordinated care delivery. The fact, as previously mentioned, that our teams are essential and that teams include the patient, and some of the other speakers here will speak to that issue in more specificity. Quality, safety, affordability with metrics that we can measure and performance that we can measure as effective teams. Care that has to be value-driven and evidence-based. And all of it is founded on the bedrock of the triple aim of better health care for individuals, better overall care quality for populations, and better value and cost management for the delivery of care that we render. So there's an awful lot of common ground here, and that's been particularly for me, a delight to be able to be involved in both sets of activities over the course of the last 2 or 3 years. With that, I'll pass it along to Dr. Matthew Winio from the American Medical Association and ask him to provide some background. Matt was one of the lead authors on our paper and helped us develop the approach to the development of the paper and the activities that have resulted from it. Matt, welcome to the webinar.
Thank you, Ed. And I just should start by saying what a pleasure it has been to work with this team. The genesis of this was, as Ed mentioned, within the Best Practices Innovations Collaborative. And as that group was mulling over how best to approach team-based care, given that there's a crowded field here, a lot of folks have worked on team-based care in the past. And one of the things that we thought we might be able to contribute would be to put together a team of people from the Innovations Collaborative who would, in some ways, reflect or mirror a common framing of a clinical team. And so you'll notice that we had, someone from patients like me, and we had a physician, and we had a nurse, and we had a PA, and a pharmacist, and a social worker, and it felt very much like some of the clinical teams that I've also had the pleasure to work with over the years. And where we started here was with a very comprehensive literature review because we did realize we weren't walking into an open field. We were walking into a field where there had been some very good work in the past. And what we were seeking in our literature review were common themes and elements that we had initially framed as principles that guide high-functioning teams in their work. So we were trying to be fairly practical about this, and we did a lot of reading and came up with what we thought were some common principles that might guide the functioning of highly effective teams. And then we wanted to test these principles. So this is basically just a one-pager, a document that said here are some guiding principles that we think might be important. And we wanted to then bring this to some high-functioning teams. So we started scouting around, and through the literature review and importantly through recommendations of people on the roundtable, the IOM Roundtable on Science and Value-Driven Care, we received a number of suggestions of teams that we might want to interview. So we sent every one of the teams we were recommended. We did a little background on to make sure that they were, in fact, that we could document that they were high-functioning teams. I won't go into detail on that, but every single one of them that we were recommended, we contacted, and they all agreed to be interviewed. And we sent them in advance. We talked to several people from each of these teams, and we sent them in advance our draft set of principles. And then we talked to the teams about how those principles, well, first of all, whether those principles made sense to them, whether they resonated, whether they thought, yeah, in fact, this is kind of the guiding, these are the guiding principles that help us in our work. And then we asked some specific questions about how those principles played out in practice. And these teams, these interviews rather, were, it says it's scripted here, and in fact there was a semi-structured interview protocol, but I would put more emphasis on the semi than the structured. These really often turned into fairly wide-ranging discussions, although there were a number of very common themes. We're going to get back to that in a couple of minutes. One of the very early themes that we heard over and over again was the intersection between these sort of practical principles that guided the work of teams as a whole and the values that governed the behavior of the individuals on the teams. And that's something that I'm going to turn over now to Pam Mitchell to talk a little more about that intersection, because I think it was an early learning point for us that the things that make teams effective are not just that they operate on shared principles, but that they also hold shared values.
Thanks, Matt. So as you will gather as we go through this webinar, even though this looks like a pretty linear process if you read the paper and the way our slides are organized, it was definitely reflective, iterative, moving back and forth. Before I move into the values part, I do want to remind folks of the definition that we've been using. that team-based healthcare is the provision of health services to individuals, families, and or their communities by at least two health providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated high-quality care. That's a really fancy way of stating the triple aim, but it underlies all of this. And as we were working with the literature in our own discussions as a team, and then in the interviews with these high-functioning teams, we recognized that underlying and interacting with the principles, which we'll outline later, are a set of personal values that were critical to being able to work together as a high-functioning team. So of these values, the honesty is reflected in the value that team members place on transparency about aims, decisions, uncertainty, and mistakes. It's absolutely central to the principles that we outline later. Without honesty with oneself or other team members, it's nearly impossible to establish mutual trust. And without honesty with oneself and with others, communication will falter and the roles are difficult to clarify. So honesty runs through all of the principles. The discipline is central to carrying out the clarification of our roles and responsibilities, even when it's difficult. As individuals and as a team, we need to seek out and share information that improves our function, even when that is uncomfortable. This is what helps us to set and stick to the protocols and the standards that we intend to work with. The creativity is the thing that is the juice, I'd say, that incents us and keeps us going. That was clearly one of the joys of working together with this team, and one of the things that was expressed in all of the interviews that we had with high-functioning teams. It means we're excited about the possibilities, about sharing to tackle new and emerging problems. And it means that we see errors or anticipated outcomes as opportunities rather than crushing failures. It's very likely that this is the value that incites curiosity, which I'll come to at the very end. We also recognized, as in the course of these discussions, that humility is absolutely critical. That really underlies our ability to rely on each other and to recognize and avert failures, no matter where each of us lies in the formal hierarchies. We recognize that we have differences in training and differences in approaches, but without feeling that any one is superior and therefore subsumes all of the others. Later, when Matt discusses leadership, this value of humility becomes a really critical one. And then the last one on this slide is curiosity, which I believe is incited by creativity. It's a reflection on the lessons that we learn in our activities as individuals and as part of a team. And you might think of it as kind of the opposite of the rumination over our failings. Rather, it's curiosity that leads us to positive reflection and continuous improvement as a value, not as an operation and a set of steps to be taken together. Oh, this is supposed to move when I click it, but it didn't do that.
I can take care of it, Pam. I'll get
Thank you.
And this is Ed Webb again, and as we transition from those characteristics of personal qualities that are essential to the individual member of the team, we then move to, as Matt mentioned, we had shared a draft set of principles around teamness and team functioning that we sought reaction to and concurrence with to identify what those are, and we'll now move through each of those five in relatively rapid order. The first of which is shared goals, and that is that the team, and critical to this, our definition and work, and critical to what we heard from the teams that we interviewed, is that the patient, and where appropriate, their family members, their caregivers, are an integral part of that team, work to establish shared goals that reflect the patient and family priorities that can be clearly articulated, understood, and supported by all the team members. The clear articulation piece is key. It goes obviously to the ability to share information across team members, the ability of evolving HIT systems to support and document and share the information about shared goals so that they can be broadly shared across the team, and shared not only technologically but intellectually and in terms of an ethical basis for the care that's being delivered. These shared goals must reflect and fully embrace patient and family priorities. They need to be transparent, not hidden in any way. They need to be individualized based on patient needs and abilities and capabilities of not only the family and patients, but team members themselves, resources that are available, respectful of patient needs and their dignity and their choice. And of course, Dr. Don Berwick has written extensively over the years about the issues of patient choice and patient engagement. And again, Matt will have some other thoughts to say about that a little bit later. Once we clear all of those hurdles, and they're not really hurdles, but they're challenges to be effective, the goals underpin the other four principles in many respects. They have to be fully supported and understood by all the team members, and it's supported and embraced and guide each clinician member of the team's approach to their own specialized work. And then those goals need to be consistently evaluated and reevaluated, measured as to achievement, and then adjusted as necessary to respond to the dynamic circumstances of the patient and not only their clinical and medical and healthcare situations, but other circumstances related to their overall health care. And Robin will mention some of those a little bit later in the program. So shared goals is really the foundational principle of the five that we were able to identify and further refine through the work of our interviews with the high-performing teams. And then Matt will take on clear roles.
Yeah. So this may seem like a kind of obvious one in the sense that when you think about teams in any other format, if you think of sports teams or an orchestra or something like that, this seems like a very obvious principle that everyone knows what their role is within the functioning of the whole. And yet in healthcare, this can actually be quite challenging. And part of that, can we go back to the definition?
Sure.
Whoops.
Sorry.
Part of that is because the division of labor is not always that obvious. There are a lot of people in healthcare who are very well trained, who can do multiple things, and it's common for there to be tasks that could be accomplished by a number of different people within the team. And as a result, clarity in role setting is actually one of the things that we sometimes take for granted. But within these high-functioning teams, that was rarely the case. These teams were very careful about ensuring that everyone understood what their accountabilities were. So that's not just a matter of saying who's going to do which task, but knowing who is actually accountable for each of the tasks. And these did not always fall along what one might call traditional lines. So we saw instances where the pharmacist acted as the functional primary care provider for patients with specific conditions. We saw cases where the clinical team meeting was run by the chaplain. And there were a number of other examples of non-traditional roles, but where the team got together and realized that one person was particularly well suited to carrying out a particular task. And clarity in that is very important. So I've mentioned a little on the complex evolving care delivery system. The issue of respect for each other's responsibilities and capabilities is very important. I think one of the things people think about in terms of the benefits of clarity in roles and teamwork is that the team can accomplish more together than it can with any single person. or with each person acting sort of independently, that teamwork, when it's working right, is synergistic. It's complementary. And so these overlapping roles end up producing end up with greater productivity than would have been accomplished otherwise. But that only works if each person not only understands the authority and accountability of each other person, but has respect for the accountabilities that other people on the team have. And this gets us to what is sometimes one of the most contentious issues in the political arena, which is, what does leadership mean in the evolving healthcare system and when working in team-based care? And I have to say, I at least walked into this discussion expecting this to be one of the most contentious issues, because in the political landscape, oftentimes, who leads the team has been a contentious issue. So one of the interesting findings, for me at least, was in discussions with high-functioning teams, this was actually not a big deal. And that had to do with two things. Number one, everyone seemed to recognize that given the complexity of team-based care today, there is rarely the desire or the need or even the possibility for one person to be the lead of every activity of the team. No one wants to do that. It wouldn't be possible to do that. And in fact, when you talk to these teams about leadership, it's a much more nuanced understanding of leadership than the sort of I'm the captain of the ship model of leadership. So leadership was not that people didn't understand who was the lead for specific tasks and responsibilities and so on, but leadership was dispersed around the team. And the other thing that we noticed was that sometimes, this leadership role would go to the patient, for example. And that gets us to the other piece of what we spent a little bit of time on in the clear roles section of the report, which is, what does it mean for a patient to become a member of a healthcare team and not the recipient of services from a healthcare team? And those are not always entirely clear. Patients as members of the team are really quite unique. This will not come as a shock to anyone here who's involved in the delivery of team-based care, but patients obviously come to the healthcare encounter with really variable amounts of expertise and knowledge in terms of healthcare knowledge. They obviously have expertise in what's happening to them. So there are a lot of domains in which the patient has tremendous expertise. But when it comes to sort of healthcare training, patients are walking in sometimes at somewhat of a disadvantage. We in healthcare tend to use a language that many patients just don't understand until they have received some degree of training in medical lingo, for example. So that's something that has to be explicitly addressed. The other thing that's really unique about patients as members of the team is that patients come and go out of the team over the course of a day, and patients will enter and leave different teams as well. So a clinical care team may spend the day together, but there will be 20 or 30 or more patients coming in and out of that team. So when we talk to high-functioning teams about how they address that, they have very explicit protocols for introductions of patients into the team. And again, for those of you in the sort of PCMH movement, this will not be a surprise, but the formality with which patients are introduced into a team and introduced to the members of the team, what the roles of those members are, and in particular the formality with which patients are given responsibilities as members of the team was very striking to me, at least. Many of these high-functioning teams have ways of, taking what Ed was just talking about in terms of goal setting and moving straight from that into, okay, who's going to do what in order to help us achieve this goal for you? And that often will involve establishing explicit, not just goals, but responsibilities for the patient. Now, some patients are prepared for this. Some patients are not. It really depends, on where the patient is at. So that's the final point I would make, is that when talking to these high-functioning teams, they were extremely flexible in terms of the roles of patients within the team. That they were very patient-centered in determining what the patient, with the patient, what the patient was capable, willing, interested in contributing to achievement of the patient's goals.
Thanks, Matt. Pam?
Right. This is just not moving for me. Thank you very much.
I got it for you.
So this, I think Matt's comments really illustrate how intertwined both the principles and values are in these high-functioning teams. So in terms of mutual trust as one of the key principles, team members earn each other's trust, and this creates strong norms of reciprocity and greater opportunities for shared achievement, and this moving around of leadership and the patient's role in the team. As I noted earlier, the mutual trust relies heavily on both our personal values and our organizational values about honesty and transparency. And I'm going to come at the end of these comments to talk a little bit more about the organizational component of it. But it's really clear that all of those values about creativity and curiosity and humility and the discipline necessary to keep the communication open in every interchange that we have as a team. And this gets much more complicated if we truly have the patient and their family as the center of that team, because as Matt said, that teamness changes over the course of the day. But every encounter, I think, creates these norms of reciprocity, establishes whether we are indeed trustworthy to each other, to be openly sharing. And I think there were some great examples out of our team interviews. So, for example, the Mount Sinai palliative care team talked a lot about how important it was, even in the hiring process of people to come into the team, to interview for those norms of trust, of openness, of transparency, the ability to share power and leadership. Now, our patients, we don't interview them for that, so we need to incorporate them and help them to see where there are the areas of mutual trust, the clarification of roles, which is a part of this. One of the community centers openly, actively documents what the contribution of each team member is to the care, and all team members see that, and that helps to do the training of each other about what our roles are, what the expectations are. And I think the example from Cincinnati Children's Hospital was a really powerful one in their family and patient-centered rounds, in which they actively include the child and the child's parents as active members of those teams. And they very explicitly explain what their roles are, as jargon-free as healthcare providers can be, and families and children quickly will say, I don't understand what you're talking about. They get feedback and comment from each child and family. So these are some of the methods that teams use to establish trust and trustworthiness in a very rapid manner with every interaction that they have. The other part that we recommend in each section of this, not only the personal and the team components, but the organizational supports that will allow mutual trust, for example, to develop. So there needs to be some time and some space and support for team members to get to know each other, including the patients and families, embedding the principles and the function of teams into the education and into the hiring process, and developing the resources and skills that help people with effective communication, including conflict resolution. One of the really fun things that we heard about this from one of the teams was what they call the culture of cake, meaning that they celebrate important events in the team, including the patients, with cake and food. It doesn't slow down their meetings. It's not a separate kind of thing, but it is a part of creating that culture of mutual trust. And I believe at this point we will turn this over to Ed. We need you to move us.
Okay. to turn it over to Robin at this
To
point.
Robin, thank you.
Yeah.
Thank you. The team, of course, effective communication is the perfect segue from what Pam was saying, and the team prioritizes and continuously refines its communication skills. It has consistent channels for candid and complete communication, which are accessed and used by all team members across the settings. And of course, this has great relevance for including the patient and hopefully the family when the family is able to be involved and the patient allows that, because so often we leave the family off the team. So when we think about these elements, we want to talk about that this should be considered an attribute and guiding principle of the team. It incorporates all of what Pam talked about in terms of honesty, discipline, creativity, humility, and curiosity, and comprises a set of teachable skills that can be developed by each member of the team as a whole. And it's really critical and many of us were not trained to be on a team. And it's so important that we take the time to know that this is a skill set that not everybody knows automatically, and that we have tolerance for those differences and able to reach out to people who are in different places in terms of the skill set. So I think that's critical. We think that's critical. It also incorporates many channels of communication for team members to achieve their purpose. Progress notes, electronic health records, telephone conversations, email, text messages, faxes, and snail mail are all critical to think about. And we need to really set high standards to ensure the consistent, clear, and professional communication. Again, that speaking clearly, directly, avoiding jargon, particularly in the patient-centered medical home and the ACO movement. Hopefully we're going to be not involving just team members that all work in the same location, but crossing over to community-based organizations where the language could be very different from what happens in a hospital setting. And how do you then feel comfortable challenging the other and asking questions? What do you mean by CHF, or what do you mean by a social service agency type term? That's critical. So we need to be able to discuss verifiable observations rather than personal opinions and feel comfortable with that, listen actively and show willingness to learn from others. A great example from our paper is at Park Nicollet, where they're all encouraged to attend the team meeting and ask questions and share ideas, and no questions are considered not appropriate. Also, recognizing the value of deep listening and engaging listening at many levels is very critical. How do you listen actively and model for other team members? How do you listen to the contributions of others on the team, including the patient and the family? How do you recognize the value of questions to clarify and learn from each other? Are all very critical. And then the whole notion of requiring continual reflection, evaluation, and improvement. How do we measure our success? And I'll get to that in a minute, but how do we look at how we're doing communicating with each other? Are our communication skills, are they teachable? Are they learnable, as I mentioned? How do we recognize and call out signs of tension and conflict? They're inevitable, so why sit there with the elephant in the room rather than talking about it? It's very important to be able to have a culture that you can talk about it, work through it, and get beyond it to improve that communication pattern. So it's important for organizational factors to consider this, to provide time, space, and support to meet. And we heard that from a lot of the teams we talked about, that somewhere there has to be a top-down emphasis that teams are important to ensure the proper training and communication and expectations and techniques, and to utilize our digital capacity as much as possible, web portals, including the patient and family. With all coming down to that, information sharing is the goal of communication, and that all team members need to recognize that this includes both technical and affective information, the emotional side of things too, not just the facts and figures. So if we can go on to the next one, Ed, we're going to talk about the measurable process and outcomes. And we all agreed that the team agrees on and implements reliable and timely feedback on successes and failures in both the functioning of the team and achievement of the team's goals. These are used to track and improve performance immediately and over time. We know there's some measures of team goals out there, but we cannot reinforce enough that in order to develop the coordinated, high-quality, patient-centered care, it requires rigorous, continuous, deliberate measurement. And if we learn how best to do this, how it might differ among different populations, and how to incorporate what's learned into the emerging learning health system, we're all going to be better. And this is probably an area we would all agree that needs more work in an ongoing way. And we want to talk about both process and outcomes, the process reflecting the impact of the care processes on outcomes, and then the overall outcomes are to reflect the uniqueness of the team and what matters to patients. The patient outcomes can be from various sources for different purposes, but there's very little in the literature, practice, evidence that connects the team functioning to the patient outcomes, and I think that's just a piece that we want to continue to hone in on that needs future work. So how do you say how the team has an impact on condition-specific patient-reported outcomes? And there's ways to do this, of course, through focus group input, safety reports, satisfaction surveys, coordination of care within the team and across settings of care. And that team outcomes can assess the team's development, and of course maturity over time would be very important too. And value outcomes can measure the impact of these team-based care on the cost of care. Those would be critical because there's not a lot that incentivizes care teams in our payment delivery structure at this point, and we feel that this area would help hone that and incentivize it and make it more normative care, which we all know should exist in order for our patients and families to get what they need most from our systems of care. So on that note, do I hand it back to Ed?
It comes back to Matt,
Matt,
I think,
sorry.
at this point. And Matt, maybe reflect a little bit on the accompanying JAMA viewpoint piece that was that the group that you and Pam in particular put together to kind of lay the groundwork for, okay, kind of where do we go from here? What was our learning experience, and what are some of the issues that need to be considered?
Yeah, I think we've touched on each of the, well, at least two of these, and to a certain extent the third of these where to from here points already during the webinar, but I'll just emphasize a couple things. The interviews were remarkable in part because this question of how to integrate patients into team-based care was something that was a recurring theme in almost every one of them. And so we have been giving additional thought to something like a developmental model for patients moving from being the recipient of services, the recipient of team-based care, to being more like a participant in team-based care, and eventually to being a sort of full-fledged, if you will, member of their healthcare team. And there's recognition that, again, not every patient maybe needs to be a full-fledged member of a healthcare team. There are transaction costs and meaningful financial costs in establishing and maintaining healthcare teams, and not every patient needs a big team taking care of them. Some folks either don't need that for clinical reasons, or they're unprepared for being a member of such a team for a variety of other reasons. And so speaking to these high-functioning teams has led us to do some further thinking about, what are the metaphors that work for describing the patient's role on the team. And people sometimes talk about, the patient as a quarterback. That doesn't actually work very well if you think that the rest of the team, then that means has a different quarterback for each play of the game. So we've started to think about other ways of drawing metaphors, and I would love to actually hear from other folks on the call during Q&A time if there are better metaphors to describe teams in healthcare than the sports metaphors that we so often hear. The other thing we've spent some time talking about are what are the structural and organizational and financial supports that are necessary for patients to become members of their healthcare teams. Many of these organizations that have high-functioning teams do some very specific things to try and support the functioning of those teams. There's space available. There's time made available. There are decision support tools. There are structured communication tools around intake forms, around structured interviews to help patients to both elicit goals, establish roles, and ensure that they understand where each person's responsibilities lie. Another area, though, when you start thinking about organizational and policy supports, it's the second bullet point on accountability and flexibility on teams. We have seen some important advances in the last year or so, and I expect we'll continue to see increasing policy and financial supports for accountability across teams rather than our traditional systems of accountability in healthcare, which often focus on the individual. And the patient safety movement has sort of, one likes to believe at least, long ago moved away from the individual shame and blame model. But many of the policy supports and the financing mechanisms in healthcare have not yet moved beyond shame and blame. And haven't figured out how to reward teams for high-functioning activities across a range of health professionals and patients. And then finally, education and training for teamwork has been a long-time interest of the Institute of Medicine and a number of other groups. And so there are a lot of intersections between the principles and values that we've outlined and the training frameworks that, for example, the Interprofessional Education Collaborative has put together. And one of the things that we're very interested in looking at moving forward is how to connect up interprofessional education with interprofessional practice. And there's certainly a sense in some quarters at least that there are a number of schools, medical schools, nursing schools, pharmacy schools, and so on, that are doing effective interprofessional education during the undergraduate education time frame. But then those students too often move into a training period during residency for physicians and so on, where they don't see high-functioning teams in practice. And as a result, what we sometimes call the hidden curriculum takes over. And it's a little too common right now for students to say, well, that team-based care looked good when we were hearing about it in the classroom and when we were practicing it in simulation lab, but in the real world, I'm not seeing that happening. So that must be one of those things that is an ideal that they teach us, but in fact, in practice, this is how the world works. And it's not like that. So figuring out how to connect up the educational system with the sort of on-the-job training that is so much of healthcare learning, and in fact is lifelong learning for health professionals, is a key interest for us moving forward. And back to you, Ed.
Thanks, Matt. We've come to a point in time where we can perhaps take some questions. I have been monitoring. We have a few online, and I'll try to throw those out to the group and see. There are a couple of related themes at least, but I don't want to miss the opportunity to also thank the Institute of Medicine's staff who supported our team so well in helping to put this paper together, to do the interviews, to spend time with the high-performing teams on the telephone. Valerie Rohrbach with the Institute of Medicine, many thanks to her for her work, and also Dr. Isabel von Cohorn, who was the chief program officer at the time that our paper was put together. Isabel has since left the IOM, had a third baby, and is doing quite well. Actually, she's a board certified neonatologist by training, and looking to move back into clinical practice at some point. But without the IOM, those two members of the IOM staff, we couldn't have accomplished this work nearly as well. I don't think so. Many thanks go to them as well. A couple of questions that have come across in the stream that maybe I'll try to collapse together. One is the issue. One question was raised about the issue of how do you share goals with patients, which suggests which leads to then the question, well, if the patient is involved in the goal development, then do we need to share with the patient? So an interesting issue of goal sharing versus goal development in terms of patient care. And then probably a related question, how can communication with patients and families occur effectively when the caregivers are sometimes specialists or subspecialists who are consulting in the care but not necessarily overall responsible for it and only engaged intermittently. So would any of the team members like to take on those semi-related questions?
I can get us started, I guess. I think this certainly is, it's related to the issue of effective communication. And the hope has been, and it's only been partially realized, if that with improvements in electronic technologies, that we would have much better communication across different sort of far-flung healthcare teams. One of the things I don't think I mentioned earlier, but we did recognize within this work, and we heard from the practices, that there are often well-structured, high-functioning teams, but those teams still have to deal with the rest of the world. And so you can have terrific communication and mutual respect and trust and high functioning within a particular setting, but patients don't receive care from just one setting. They move around the healthcare system as necessary to receive what they need. And so it is really up to us to start figuring out how to ensure effective communication across teams and not just within teams. That's not an answer. It's just to be, I'm sympathetic to that concern.
This is Pam. Sort of to follow on, certainly in the course of creating the goals for the team that includes the patient, that's both sharing and creating. And so I think that process can be extremely effective. I'm thinking about a recent experiment. Robert Wood Johnson had a several-year project, and I've suddenly forgotten the name of it. I'm sorry, but it's one in which the patient and the care providers are all recording together in that patient's record. It really opens up.
Open record.
Open record. Thank you, Robin. This is a marvelous strategy, in my view, in which we can have the openness of what the roles are, what the questions are, the sharing of goals, and it seems to have been very effective and did not open people up to lawsuits, which was one of the big concerns, I think, of the physicians who were involved in that. So there are some little pockets of things, but this is an important question because we're not trained as healthcare professionals. Really, we talk about patient-centered care, but we're really not trained in how to engage the people who are the recipients of our care in the sharing, in the goal setting, on an ongoing and inclusive basis. So it's a big challenge for the future.
Robin, any further thoughts on that?
No, I couldn't agree with everybody more. And again, I think there's some innovative things, and just how complex it is, and I that we need to grapple with this. That Home Alone report that AARP produced in September that talks about the family caregiver. We're sending people home with the most complex things that they're doing all alone. Just speaks to how important it is to have them engaged in the process, because so often we forget in our healthcare system, in our long-term care system, that the family really is the backbone of our formalized long-term care system as it exists right now, and why their preferences, values, just like the patients, need to be incorporated into the overall plan and team discussion.
Yeah, I'm reminded of the song from Rent, 525,600 minutes.
Yeah.
Which is the number of minutes in a year, and I always think of that when I think about my own patient. I'm an HIV doctor, so I actually see my patients probably more often than most other patients get seen in a year. But I will be with one of my patients maybe an hour, so maybe 60 minutes out of the year. The other 525,540 minutes, that patient is managing their condition. And recognizing the relative paucity of control that I have has really made me much more engaged in trying to make sure the patient understands what they are managing, and and why, and why certain things are being asked of them, and so on.
Yeah, this is Pam again. I just recognized that I used the term of the people who are the recipients of our care, and that slipped out because that's just so often, and that's absolutely antithetical to what we've been talking about in the paper. The people who are the partners in their care. I was reflecting on one of the questions that came up about why are we continuing to use this term patient, which implies a lot of passivity, and I couldn't agree more. I'm not quite sure what to call, but I guess the people who are the partners with us.
Yeah,
in
care
care
partners seems to be being tossed around.
Well, Pam, this is Ed. You've obviously mastered the technology now because you're monitoring the questions just like me. So, and that was the next one I was going to bring up. So that's great. We are just about at the end of our time for the webinar, but I want to thank my colleagues, my teammates, my friends for being a part of this this exercise today. We have, as all have said, we have gained so much individually, personally, from having worked together on this as a team, and we're looking forward to future opportunities to do that same thing. The link on the questions slide provides a direct link to the paper that we have discussed. We again encourage everyone to take a look at it, download it, share it with people that you work with, that you're trying to as you try to address this issue in your particular patient care setting or practice or organization. And we welcome further dialogue and comments on this, and hopefully we'll have a chance to meet in person across the next few meetings and venues to discuss this. I will just take one brief minute to mention the upcoming conference in Philadelphia in March on the Patient-Centered Medical Home, a multi-organizational conference of which PCPCC is a supporting partner, and then also to make note of the Washington, D.C. based fall conference of the Patient-Centered Primary Care Collaborative, information about which is continuing to evolve and grow, and is available on the PCPCC website at pcpcc.net. So with that, I will again thank my colleagues, thank all the people who took the time today to give up. Hopefully you had a sandwich while you were listening to this stuff and took the opportunity to share your lunch hour with us if you're on the East Coast, or breakfast if you're in Pam's case. And we appreciate you being with us today, and we look forward to further dialogue on this among everyone who is interested in it. Thanks so very much, and thanks to the PCPCC staff for the great technological support to get this done today. Thanks so much.